Good day everyone, this is Christine Lazaga and together with me is J. Anthony Chua, and today we will be reporting about dehydration in intestinal obstruction. So to begin with, let us first briefly discuss dehydration. So dehydration occurs when the amount of water leaving the body is greater than the amount being taken in, while intestinal obstruction is a blockage that keeps food or liquid from passing through your small intestine or large intestine, also known as your colon.
Intestinal obstruction has a high mortality rate if it is not diagnosed and treated within 24 hours. Etiology and risk factors. Bowel obstruction may be caused by narrowing of the intestinal due to inflammation, neoplasms, adhesion, hernia, volvulus, and intussusception. Food blockage, compression from outside the intestine. Cancer. Other causes are diverticulitis, ulcerative colitis, and previous abdominal surgery. Factors causing intestinal obstruction may be mechanical, neurogenic. So let's move to the anatomy and physiology. The gastrointestinal system is a long hollow tube that passes through the body, providing an isolated environment for digestion and absorption of nutrients. Ingested content pass sequentially through the following structures: mouth, esophagus, stomach, small intestine. These are duodenum, jejunum, and ileum. Large intestine, colon, before exiting the body at the anus. The stomach is divided into the fundus, body, and antrum. Food can be stored and mixed in fundus and body for up 1 hour. During this time, there may be separation due to density because fats flow to the top and liquids accumulate on the bottom. Liquids are the first to leave the stomach and to be absorbed through the intestine. The small intestine divided into 3: duodenum, which is 25 centimeters in length, jejunum 2.5 meters length, ileum 3.6 meters. The duodenum and jejunum are the major sites of digestion and absorption. Large intestine includes the cecum, a pouch where small and large intestine join and from which the appendix projects. The ascending, transverse, ascending, descending, and sigmoid colon and rectum. The large intestine contains mucus-secreting goblet cells and cells specialized for absorption. It lacks villi and does not produce digestive enzymes. Internal sphincter, which is smooth muscle. External sphincter, which is voluntary muscle, govern the expulsion of feces. The large intestine, also called colon, is part of the digestive tract. Ascending colon, on the right side of the abdomen, is about 25 cm long in humans. It is the part of the colon from the cecum to the hepatic flexure. It is secondarily retroperitoneal in most humans. The next is the transverse colon. Is the part of the colon from the hepatic flexure to the splenic flexure, the turn of the colon by the spleen. The descending colon is the part of the colon from the splenic flexure to the beginning of the sigmoid colon. The function of the descending colon in the digestive system is to store food that will be emptied into the rectum. Sigmoid colon, the next, is the part of the large intestine after the descending colon and before the rectum. Sigmoid means S-shape. The walls of the sigmoid colon are muscular and contract to increase the pressure inside the colon, causing the stool to move into the rectum. The large intestine has 3 important functions. First, absorbing water and electrolytes. Second, producing and absorbing vitamins. And third, forming and propelling feces toward the rectum for elimination. Fluid and electrolytes. Fluid and electrolytes balance is fundamental to the process of life. Abnormal fluid volume can alter physiologic homeostasis and can be life-threatening. Fluid and electrolytes in the body are found in the cell. The intracellular fluid compartment, it is inside the cell, and the extracellular fluid compartment outside the cell. Water has many important functions. First, maintenance of blood volume. Second, cellular transport of vital substances. Third, transport of cellular waste products to the lungs and kidney for removal, lubrication, and cushioning, hydrolysis of food in the digestive system, reactant, and medium. Let's go now to dehydration and bowel obstruction. Dehydration, it is a fluid volume deficit from excessive loss of water, occurs frequently in infant and children, and adult also, as a result of many diseases. It happens when our body does not have as much water as it needs. Without enough, our body cannot function it well. Bowel obstruction, it is an interruption in the passage of bowel content. Approximately 90% of bowel obstruction occur in the small bowel, especially in the ileum, which is the narrowing segment. Obstruction of the small intestine are a common surgical emergency. Obstruction produces nausea, vomiting, dehydration, and severe pain. As we know that electrolytes are hydrogen, sodium, potassium, magnesium, calcium, sulfate, and phosphate, and etc. So there are three types of dehydration. Isotonic, most common form, water and electrolytes losses are about equal. And then hypertonic, there is greater loss of water than electrolytes. Fluid moves from the intracellular to extracellular spaces. And hypotonic, electrolyte loss exceeds water loss. Fluid moves from the extracellular to the intracellular spaces. Now I'm going to discuss the pathophysiology of dehydration and bowel obstruction. First is the mouth, where the food starts to move through our GI tract when we eat. When we swallow, our tongue pushes the food into our throat, followed by going to the esophagus and lower esophageal sphincter and going to the stomach, where digestion occurs. After food enters our stomach, the stomach muscle mixes the food and liquid with digestive juices. Then, small intestine mix food with digestive juices from the pancreas, liver, and intestine. And the small intestine is the one to absorb water and digested nutrients into our bloodstream. As peristalsis continues, the waste products of digestive process move into the large intestine. And the large intestine absorbs water and changes the waste from liquid into stool. Peristalsis is the one to help move the stool into our rectum for elimination. Let's move to predisposing factors due to inflammation, neoplasm, adhesion, hernia, volvulus, intussusception. Cancer is one of the chief source of bowel obstruction, tumors, blockage, and electrolyte imbalance. And the other side, the precipitating factors due to lifestyle, poor diet of the patient, low fluid intake, fat intake, and also the medication. It can cause factors of bowel obstruction. Next is edema of the intestine. There is a blockage in the rectum or in the colon that prevents the food or gas from passing through. So there is an accumulation in that area. The fluid, electrolytes, and serum proteins are not excreted, so they are retaining there in that area, so which may lead to severe vomiting to the patient and pain. Once the patient is vomiting because of the partially elimination of the fluid that accumulated there, so there is a dehydration and electrolyte imbalance because all the electrolyte were excreted due to vomiting, and then it may lead to severe reduction in circulating volume, which may result hypotension, hypovolemic, diminished renal cerebral blood flow due to the poor blood circulation throughout the body. And fluid was lost, but the red blood cells are not, so hematocrit and hemoglobin value rise. White blood cell, BUN, related to kidney, is high, sodium and potassium is low due to vomiting. Then increased potential vascular occlusive disorder due to the poor blood circulating volume. Then it may lead to fluid distension. And then there is a large volume secretion in a small bowel. It can add more to the distension in the fluid distension. So, and then it causing a temporary increased peristalsis as the bowel attempt to force the material through the obstructed area. And then once there is a temporary increased peristalsis, it may become to the peristalsis ends, and it would result to decreased peristalsis. Once the peristalsis is decreased, the bowel becomes flaccid. So next, increased fluid retention. Electrolytes rich fluid is secreted by the bowel, and most all the fluids was reabsorbed. When the bowel is obstructed, the fluids are partially retained within the bowel. So there is an increased venous pressure, increased capillary permeability. So bone become permeable to bacteria. So prone to bacteria na ang bone. Increased peristalsis. In a bowel obstruction, increased peristalsis because the bowel wants to forcefully push the material through the bowel, and then decreased absorption, increased secretion, large accumulation of the fluid, electrolyte, and gas in that area, edema of bowel wall, obstruction, and fluid bacterial permeate bowel wall, which may lead or which may cause peritonitis. So decreased arterial blood flow, necrosis, toxemia, and peritonitis. So the medical management are preoperative IV fluids, IV analgesia, IV antibiotic, and NGT, and surgical bowel resection, insertion of intestinal tube. The nursing management, reduce of the rest of some forms of bowel obstruction by modifying diet and lifestyle, encourage to eat balanced diet, vegetables and fruits, regular exercise, encourage the patient to see the doctor once a year for rectal screening once a year after the age of 50. And that's all my pathophysiology. I will give the floor to Christine to discuss the signs and symptoms. Thank you.
So let us now proceed to the signs and symptoms. So for small bowel obstruction, the signs are the following. Cramping abdominal pain, generally coming in intense waves that strike at intervals of 5 to 15 minutes and sometimes center either on the navel or between the navel and rib cage. Nausea and vomiting, no gas passing through the rectum, a bloated abdomen, sometimes with abdominal tenderness, rapid pulse and rapid breathing during episodes of cramps. Next is the symptoms of large bowel obstruction. This include a bloated abdomen, abdominal pain which can be either vague and mild, and sharp and severe, depending on the cause of the obstruction, constipation at the time of obstruction, and possibly intermittent bouts of constipation for several months beforehand. If a colon tumor is the cause of the problem, a history of rectal bleeding such as streaks of blood on the stool is to be done. Next is the diarrhea resulting from liquid stool leaking around a partial obstruction. So let us now proceed to its diagnosis. So to diagnose a bowel obstruction, your doctor will need to feel and listen to your abdomen and feel inside your rectum. A blockage in the intestine is confirmed by having x-rays of your abdomen, which show gas and liquid bowel contents above the area of the blockage but no gas below the blockage. Blood tests must be done to check for dehydration or loss of electrolytes such as sodium and potassium if your symptoms have included vomiting. If your doctor suspects you to have a large bowel obstruction, he or she may use a colonoscopy, a tube that is inserted through the rectum to review the lower intestine. If the obstruction is caused by a volvulus, the passing of this instrument into the bowel not only confirms the diagnosis, but also untwists the intestine and relieves the obstruction. It may not be possible to know the cause of a bowel obstruction unless surgery is done. Surgery permits a doctor to look at your intestine and at the scar tissue if you have adhesions. So this is the expected duration. Symptoms of small bowel obstruction and large bowel volvulus usually become severe over a period of hours. However, large bowel obstruction caused by colorectal cancer or diverticular cyst may worsen more slowly. Some patients have mild symptoms for several weeks or months before seeing a doctor. Once the diagnosis is made, a hospital stay is required and may last for several days. With successful treatment, the obstruction is relieved. So for our treatment, if you have a bowel obstruction, you will be treated in a hospital. A flexible lubricated nasogastric tube or NGT can be inserted through your nose into your stomach to help remove excess gas from your stomach and intestines. You will be given fluids intravenously through a vein because you will not be allowed to eat or drink. Partial small bowel obstruction often improves within a few days, and the NG tube can be removed if one was used. At that point, you will be given sips of fluid. If you tolerate this, you will be given a full liquid diet for a day or more, followed by solid foods that are easy to digest. A complete bowel obstruction often requires surgery to correct or remove the cause of the obstruction, such as tumor, adhesions, and stricture, repair the hernia, or fix the segment of intestine at risk of repeated volvulus. During this surgery, a segment of damaged or strangulated intestine also may be removed. It is sometimes most practical for your doctor and you to take a wait and see approach if you recover from one or two episodes of bowel obstruction without surgery. You may eventually require surgery to correct the cause of the blockage or to prevent future episodes, but not everyone needs surgery.
So that would be all for our report. Thank you so much for watching and have a great day. Goodbye!
Thank you for the world that awakes in the dawning light that breaks, and for the sunlight kissing my face. Thank